like to turn it over to the president of our co-sponsor, CTIA, the Wireless Association, Steve Largent. Steve has been president and CEO of CTIA since 2003, and I think as almost everyone knows, prior to that, Steve represented Oklahoma's 1st Congressional District in the House from 1994 to 2001. Among other responsibilities, he served on the Telecom Subcommittee at Energy and Commerce and was vice chair of the Energy and Air Quality Subcommittee. And probably most notably for his fans outside the Beltway, Steve first achieved fame as a record-setting wide receiver with the Seattle Seahawks for 14 years and was inducted in the Pro Football Hall of Fame back in 1995. Steve?
Thank you, Michael, for that very kind introduction. I appreciate that. We're certainly pleased to be working with the New American Foundation to host today's discussion. I think it's going to be interesting to talk about the infinite possibilities and solutions that mobile broadband can provide for the healthcare industry in the United States, and we're very excited about that. Over the next few hours, you're going to hear from experts in public and private organizations about how technological innovations are being developed for the healthcare industry. You'll hear about the current real-world examples on how your mobile device, such as your cell phone or your smartphone, can be used. By having public and private groups working together, we're going to develop better products and solutions because we'll share our knowledge, our experiences, and our ideas. And we're starting that process today. America's wireless industry is the most efficient commercial user of spectrum in the world. Did you know that? Our industry does more with less than any other country. And as new products and services are developed, like we're hearing today, it's never to be able to use them in secure and stable spectrum. So that's our little pitch for providing more spectrum for the wireless industry. The wireless broadband possibilities are exciting for us to develop and offer. The industry is eager to help millions of children that have limited access to doctors or medicine. You'll hear about that this morning. And for family members who are constantly worrying about their loved ones. And the world-class doctors we have in the United States who are able to do more efficiently meet their patients' needs in urban and, more importantly, in rural settings. I know I've talked a lot about the possibilities here this morning, but I want to show you a brief video that illustrates a real-life application or cutting-edge wireless technology that's being used to deliver superior health care in rural Idaho. Take a look. I'm supposed to touch a button. Which button do I push?
In rural Oregon, 200 miles north of Boise, Idaho, Natasha has arrived at the hospital for an important test. Her doctor has detected a potential complication with her pregnancy and has called in a specialist for a consult. The doctor is in, but she's 200 miles away. She'll be doing the exam from the head of a robot.
Vanya, can you show me the cervical spine? Why don't we start there?
Dr. Renee Bobrowski controls the robot remotely from a wireless laptop connection.
I can see the patient, they can see me, I can speak with them, I can do a physical exam. I'm then able to see the ultrasound in real time.
The doctor can defy time, distance, and bad weather to consult from virtually anywhere.
So I think the baby looks very normal and healthy.
Thank you. Since there's not a lot of access to specialists here, it's very comforting to know that we have this kind of an option.
Robodocs can even be seen in the operating room, providing real-time consultation during surgery.
Within a couple of minutes, I forget the robotics part altogether, and it's just like talking to another person. But I just wanted your opinion about this hernia orifice.
Have you considered a mesh there?
A couple of weeks ago, I was talking to a surgeon in Argentina. It's really stunning.
Just because we live in a rural setting doesn't mean we can't have urban medicine. we can have access to cardiologists, pulmonologists, neonatologists, all those things.
Thank you, doctor.
With the wireless and robotic technology, it's personalized, and patients are the ones that benefit from that.
It's pretty amazing, isn't it? That's just the tip of the iceberg as well. Our industry is constantly coming up with these kinds of innovations all the time. With President Obama and his administration focusing on trying to control the healthcare industry's costs, we believe that mobile broadband and devices are part of that solution. It's cost efficient and cost effective. With more than 270 million subscribers, we have more customers than cable or landline today. So at CTI Wireless, our annual trade show next week, one of our major focuses at that trade show will be on wireless healthcare initiatives and solutions. I'm looking forward to seeing some of you at our conference, and I'm confident that this is only the beginning of many discussions that we'll have and continue to have in the future. So enjoy the conference today, and I look forward to spending time with you. Thank you.
Thanks, Dave. That was a good preview of what's to come. Well, next it's my pleasure to welcome Craig Barrett, who is someone else who really needs no introduction, but I will do it anyway. Craig is the chairman of Intel Corporation, so he comes from the land of innovation here today. And Craig has become a real global evangelist for the role of information technology in improving healthcare and education, and generally raising social and economic standards globally. Dr. Barrett also serves as chairman of the United Nations Global Alliance for Information and Communication Technologies and Development, and is an appointee, as well to the President's Advisory Committee for Trade Policy and Negotiations. Dr. Barrett joined Intel in 1974 as a technology development manager and worked his way up to the top, becoming Intel's 4th president in 1997 and chairman of the board in 2005. He also co-chairs the Business Coalition for Student Achievement, the National Innovation Leadership Council, and a number of other do-gooding boards and policy bodies that are too numerous to list here. So welcome, Craig Barrett.
Well, good morning. It's a pleasure to address this audience on one of my favorite topics. And let me tell you briefly why I'm interested in this topic. First of all, I'm one of the oldest guys in the room, so I'm interested in healthcare in my retirement, which you're going to pay for. Secondly, I'm still working, and I work for a large company that has over 50,000 employees in the U.S., and we pay for their health care. I'm also a small business owner, and my wife and I own a resort in Montana. We have about 75 employees in our high point in the summer and provide health care for them. I also have 45 horses. I provide health care for my horses. Well, note in passing that all of my horses have electronic medical records. They get home care. They get better medical service than my human employees in Montana. And there's a reason for that, because the veterinarian service is in fact competitive and gives the patient or the owner of the patient choice, and that service provided is totally different than the human health care we have. Just remember that as we go through the discussion today. I'm also interested in healthcare from a purely economic standpoint, and one of my hot buttons is the debate that continually goes on in Washington. The debate in Washington is how to fix the healthcare crisis, which is usually nothing more than a balloon squeeze in terms of who's going to pay for healthcare. There's very little discussion of how much healthcare costs, what you can do to increase the efficiency of healthcare, and what it does to U.S. competitiveness. Put that in perspective. If you take the total healthcare costs in the U.S., and it's an average, and healthcare is not average, as mentioned earlier, 80% of it is in the aged, chronically ill, but if you take average healthcare costs for a family of 4, one of our employees has a wife, husband, 2 children, it's about $30,000 a year, which is more than the fully loaded cost of an equivalent worker in most of the rest of the world. So healthcare costs exceed the total loaded cost of an engineer in China, Malaysia, India, just about any place else. There's a competitive issue here. The discussion in Washington, D.C. is usually a balloon squeeze on who else can we get to pay for healthcare costs. It's not how do you fix the system, how do you provide better care at lower cost. It's who can we tax, how can we shift the cost of healthcare. That's the easy part because you just pass legislation and you do that. The more difficult part is how do you make the system more efficient. The way you make system more efficient, in my opinion, and we'll talk a little bit about it, is in fact to use technology. Technology has made every other industry in the world more efficient, more effective, provides better service at lower cost to the end user. Healthcare has great technology, but it's standalone technology, CAT scans, MRIs, standalone pieces of equipment. There is no healthcare system if you define it from a system standpoint. There's a huge opportunity. Wireless plays a role in that, but there's a lot of other things that need to be done. So with that little bit of an introduction, and if you see some emotion in my voice, you'll understand why, because it's for my kids and grandkids, it's for my employees, not my horses, they're taken care of, but human employees, and it's a competitive issue for the United States. You can't spend $2.5 trillion a year on health care and have it escalate in cost by 8% a year, which is the cost, more than the cost of the Iraq War, compounded every year. So you just think of the trillion-dollar deficits we're looking at, you look at the 40 to 60 trillion of unfunded healthcare liability going forward, and 200 to 300 trillion a year in increased healthcare costs. Somebody ought to be doing something about it besides debating who pays for it, because there's not enough money in the United States to pay for healthcare costs as we know it today. So the challenge is the cost. You just can't let the cost continue to increase. Part of that challenge is healthcare is not a consumer-centric issue because the consumer in healthcare has absolutely zero purchasing power. The government has a huge amount of purchasing power. Here in Washington, I can love to say this, the government spends about 50% of all healthcare spending. The government decides to do something, they're the big 800-pound gorilla. They can switch overnight what happens. They can dictate that we'll all have electronic prescriptions. They can dictate that healthcare delivery is not defined as a face-to-face delivery mechanism in the doctor's office. The government is the only 800-pound gorilla. The largest corporation spending on healthcare is way less than 1% of the total. So the government's the big payer. The rest of industrial America pays about the other 50%, but we're not organized like the government is. We can't make a decision overnight amongst all of us to impact how healthcare is delivered. We're trying to do that. We're trying to get organized. But right now, the government has the ability to almost make a decision overnight and change the way healthcare is delivered, if they chose to do. I'll make a few comments about that later on. There's a lot of money put in the stimulus package for healthcare, electronic medical records, broadband. That's great. The issue is, how are you going to spend that money? You're just going to throw money at computers in doctors' offices? That'll be very interesting because we'll have isolated medical records. It's not going to do anything to change the system. We can just throw money at broadband. That's cool. I love the example you showed, Steve. I've got a ranch in Montana, which is right next to Idaho. I don't have broadband delivered any sort of terrestrial sense. I don't even have cell phone coverage in my ranch. My horses still get good medical care though. But I'd love to have broadband. My wife just finished a stint as U.S. Ambassador to Finland. I can tell you, wherever you go in Finland, sparsely populated country, north of the Arctic Circle, all the way to the Barents Sea, there is great broadband wireless coverage throughout the entire country. I live in a fairly rural setting in Montana. I have no wireless coverage at all. There's a huge opportunity to put broadband wireless in. You'll see more demonstrations beside the simple video we showed you earlier. But the stimulus dollars need to be put in place with an endpoint in mind, and that endpoint in mind is not just give everybody health care in the U.S. That's a noble goal, It should be a given. The stimulus dollars should be put in place with how do you give everyone better health care coverage at lower cost, higher quality. Stop thinking about the system, which is what healthcare debate has all been about. Start thinking about the customer, like every other industry focuses on. Give the customer better service at lower cost. And there should be that endpoint in mind for the stimulus dollars. So just continue to think lower cost, improve quality, as opposed to the healthcare crisis is 45 million people who are uninsured. The government will figure out how to sign a bill, switch the tax burden, and put another $200 billion in to give those people insurance. That's not going to do anything to fix the health care crisis in the United States, which is that escalating compounded 200 to 250 billion a year of the 8% compounded increase in health care costs with no better service. And I say no better service if you look at any health care statistic you want. Incident of chronic illness, childhood mortality, life expectancy in the United States, they are average at best. We spend way more than anybody else, and we get average at best service. And nobody is thinking about the long term. My position here is to invite you to think about the long-term issues, not just the short-term issues. So, how do you change the focus? I had the privilege of sitting on the American Health Information Community under Secretary Leavitt for 3 years and talk about how to change healthcare delivery in the United States. And in the first meeting, I raised my hand and said, why don't we have electronic prescriptions in the United States, Secretary Leavitt? All you have to do is dictate that HHS will not reimburse for anything other than electronic prescription. And within 12 months, everybody will have electronic prescriptions. You've all seen the Institute of Medicine studies on this, 100,000 people negatively impacted each year. And for crying out loud, if 4 Chevy pickup trucks have a stalled engine, we can recall 2 million of them overnight. But with handwritten prescriptions, if 100,000 people have a negative incidence, can the government do something to fix that by forcing us to have electronic prescriptions which get you the right medicine, the right dosage, and look for negative drug-to-drug interactions? 3 years later, did we have electronic prescriptions? No. 3 years later, when we said 80% of the medical cost is in fact in aged and chronically ill people, and the way to do that is in fact by remote diagnosis, remote monitoring, broadband plays a big role in that. That's where 80% of the cost is. You can't touch medical care without touching that 80% of the cost. I don't care what you do to anything else in the system. The 80% of the people who are relatively healthy consume only 10 or 20% of the cost of medical care system. Make their system 50% more efficient. You take at most 10% of the cost out of the system. That's 1 year of the compound increase in medical care costs. You don't touch the system. You focus on the 15 or 20% who are chronically ill or age, and you remote monitor, remote diagnosis like the film showed, and I'll show you another clip in a moment. That's the only way you touch healthcare costs. The first meeting of the AHIC over 3 years ago, we said you need to redefine the definition of health care from a face-to-face office visit to delivering health care that benefits the consumer. Pretty simple way to change it. How does Medicare reimburse doctors today, 3 years later? How is most doctors around the world, around the U.S., reimbursed? You've got to go to the doctor's office, face to face. Until you start to think about changing the system, all of the discussions we have about broadband delivery, all this great ideas technology has to deliver better care at lower cost, go for naught. Because the system is not going to adopt those unless the reimbursement policies are consistent with the technology improvements we talk about. So let's think about containing costs, let's think about delivery system improvements, and let's think about expanding coverage. But let's not think that expanding coverage solves the healthcare crisis. Doesn't touch it. Doesn't even begin to touch it. Said in the introduction, one of my side jobs is working for the United Nations on a global alliance for using information technology for economic development, healthcare, education, etc. I get to go around the world and see examples like we saw on that Idaho and Oregon example in the film clip, I see that around the world as part of their integrated healthcare delivery systems in third world countries. And what we have to do is struggle in the U.S. to find an example of that sort of delivery, because the reimbursement policies don't support it typically. But let me just show you a quick film clip of some of the things we see going on around the world today.
I think there's pieces coming together that are going to change the game in how we do healthcare. You have these convergent everyday technologies, cell phones, PCs, laptops, all able to interconnect with each other securely and wirelessly.
Once one gets beyond the office visit as a transaction and starts to think about the population of patients and how to manage a population, that helps the capacity challenge.
The long-term care network needs to be redesigned to support people with services they need, when they need them, in a place they call home.
The more we can keep you in your own home where you don't have to make a pilgrimage to the hospital to get care, the more we can detect disease with technologies that are in your everyday life.
If we took the current labor force in primary care and asked them to see patients every 2 minutes, we still couldn't meet the needs of the growing chronic illness that we see in the future.
63% of our adults are classified as either overweight or obese. 43% of our school-age children are either overweight or at risk of being overweight.
Feedback changes behavior, and that feedback comes from various sensors monitoring the physiology.
Blood pressure, glucose monitors, peak flow meters for folks with asthma, weight scales, the opportunities are endless.
Good decision-making in healthcare requires good information, and it requires the information being available when you're making the decision.
A biópsia de pele demora 2 meses para receber resultado. Com a imagem que eu estou enviando, que eu vi agora hoje, deste sem fio, com esta câmera, o diagnóstico podia ser feito na hora.
The real opportunity is that we would strengthen the patient-physician relationship in freeing up the time of the physicians and nurses from the mundane day-to-day duties. They would be able to actually play more of a role in managing complexity.
门诊病人增加了70%，住院病人增加了140%，但是我们的人力资源问题，我们增加是28%。
我们可以收集整个人群的健康信息，然后我们就可以分析出我们当地要采取哪些。
The most important thing is the patient-doctor relationship. If I can spend less time doing paperwork, but more time interacting with the patient and nurturing the patient-doctor relationship, then I think IT would have done its job.
We've got to nationalize those solutions through an acceleration of research and development, pilot projects, and then helping these technology companies get these products to market.
You see examples in that video clip from Singapore, from the middle of the Amazon. I could have showed you similar clips from South Africa, remote villages, Egypt, remote villages, India, China, remote villages. How technology can deliver good health care at very modest cost, serving the consumer. In every one of those instances, the examination is not taking place in the doctor's office. They're face-to-face, but they're remote face-to-face, remote diagnostics, remote delivery of care. Most of the emerging world, that's necessary because the doctors are not where the patients are. The doctors are in the urban cities. The patients are typical in rural environments. The only way you get medical care there is remote, whether it's wireless or wired or satellite delivery, however it is, that's the only way you get it there. It's happening. It needs to happen in the U.S. as well. And it needs to happen specifically in the area of chronically ill and aged population. In the tech industry, in the 40 years I've been associated with it, I've seen the transformation of just about every other industry other than healthcare, incorporate technology to provide better care, better service at lower cost. And we'd like to use the following example. You know, if 30 years ago, if you wanted to do computing, where did you go to do computing? This was before the PC was invented. You went to the glass-encased room with the IBM or one of the other mainframe computers was there, and you handed your card deck in through the window, and you came back 24 hours later to see what happened to your card deck. You usually got an error message which said you wrote your program wrong, and rewrite your program, and hand your card deck in tomorrow. What we like to think of in the computer industry is we changed all that with the advent of the personal computer. We really diversified computing capability, so you do computing anywhere now. This gentleman is my prop in the front row. He's busily typing in his laptop computer. He's probably wirelessly connected to the outside world now. No? Okay. Could be. But computing's everywhere. Just think of what it would be like today if we still had to go to the mainframe. When you had your digital camera and you wanted to download your pictures, you went to the mainframe computer to do that. You went online to do shopping, you had to go to the mainframe computer to do that. You didn't have compute capability local in your home, your workplace. Now think of medical care. What's the equivalent to the mainframe computer in medical care? The hospital. You're sick, where do you go? You go to the hospital. Maybe the doctor's office or clinic, but that's usually associated with the hospital. Why don't we bring the same advances to healthcare that the personal computer brought to computing, which brought to every other industry? Why don't we diversify the delivery of healthcare so that we don't have to go to the mainframe to get the service we need? We can get the service at home, wherever we are. And you're starting to see people around the world in. My company is taking many steps in this direction. You don't have to go to a doctor's office if you go to one of the Intel sites. You go to our in-house clinic to get medical care today. You don't have to go to the hospital to get that. You can get blood tests done there. You get doctor's examination. You get prescriptions done right on site. There are lots of many steps you can take to get to where we need to go. But fundamentally, you have to change the way system is delivered. So you need new care models. People with chronic illnesses need to be monitored at home proactively so that they get caught before they get so sick they have to go to the hospital. The job is to keep them out of the hospital, not to give them better service in the hospital. The job is to keep them out of the hospital, to be proactive rather than reactive as our current medical system is. You need to engage and enable the medical profession. Access to information. Stimulus package says we'll spend 20 or 30 billion on electronic medical records. That's cool. We've been talking about a national health information network for years. If you want to wait for that, that's really good. Tomorrow I'm going to Boston to a Dossier board meeting. Dossier is a combination of 10 companies who are going to provide electronic medical records to all their employees free for them to have, personally share with whoever they want, but personal, private, and portable medical records. It's happening today. We don't need to wait for a national health information network to get electronic medical records. You can do it today. And we need to enable the consumer, the patient. The patient should have access to all their medical records. The patient should have access to medical surveillance or proactive medical care on a routine basis. These are the things we need to do as opposed to squeezing the balloon to see how should we tax the employers to pay for 45 million uninsured? How should we redistribute health care? Should it be government delivered, private delivered, some complex combination of the two? We need to get out of the debate of who pays and into the debate of how to empower the consumer and to get better care at lower cost. That's what technology can do. So, shift to the patient. What do? How does the patient get good service? I just brought you a couple of real-time examples of technology that are available today, and I think most of you have seen these examples, but I just want to show you what a broadband connection do. Something called the Health Guide. Basically a PC disguised with a very simple human interface. It actually has a camera here. If you want privacy, you just close the little spot there in the camera. But if you want to sit at home, be remotely monitored, very easy interface. I know you're going to bring that up. I just take a measurement I can take my weight, blood oxygen, peak flow, blood pressure, blood sugar. You can think of 100 other examples that I can take. There's a consortium called Continuo, 180 companies that are making plug-in devices to PCs, devices like this, which will routinely take any measurement you want, take those data, store them, forward them to a remote monitoring system, and you can sit at home and be proactively monitored if you have a chronic illness or if you're age or you just want to have your vital signs monitored. I mean, this sort of thing is dead simple, no keyboard, touch screen, big print. Anybody can use it, even me. And you can do a video conference with a device like that. If you're a medical clinician in a hospital, you want a wireless device which gives you complete, immediate access to the patient's total medical record. Such a device is this medical clinical assistant. Carry around, it's been ergonomically designed to be easy to use and fits in the palm of the hand like a baseball glove. I guess you could say it's a catcher's mitt, Steve. It's not like you NFL players use, but, you know, take the pen out, bring up an x-ray, bring up anything, bedside, no paper. The clinician spends their time analyzing data, serving the patient, not scribbling illegibly on a piece of paper. Something even simpler. I said Continuo, 180 companies who are trying to bring medical care to the individual the same way. How many of you have digital cameras? Everybody in the audience has a digital camera, right? You didn't raise your hand. What do you do with your digital camera? Hey, it's plug and play into your PC. Look at the pictures you just take, delete, save, print, whatever you want. A really expensive PC, something we make for school kids around the world, costs about $200. But it has the standard interfaces of any PC. You can take any device. A device, okay, I want to measure my oxygen content and see what my pulse rate is, hopefully. Come on, machine, work. All right, I have no pulse. That's very interesting. The last time I used one of these devices when I was climbing Kilimanjaro with my wife in Tanzania a year ago. Let's turn it around and see if it works the other way. All right, it's useless. It's supposed to work. Blood pressure, same thing can be done, but any one of these devices can be... My pulse was at 74 and I'm at 99% of my available oxygen content. By the way, when you get to the top of Kilimanjaro, it gets down to 70% or so, and they use it to monitor to see if it's safe for you to continue to climb. They can do that in Tanzania. How many of you can do that here in the U.S.? My point. That technology is available today. It's available especially to monitor people with remote capability, people with chronic illness, people of age. The job is, in fact, to keep people out of hospitals, that is really the expensive part of healthcare, and to catch them from a monitoring standpoint before they have to go to a hospital. We talk a lot about broadband capability. Nothing seems to be working today. Broadband wireless is a great way to bring broadband capability to the U.S. It's really expensive to lay fiber. It's really expensive to lay copper. Relatively expensive to lay cable into remote areas. But the new broadband wireless technologies, fourth generation technology, things like WiMAX or the long-term evolution of 3G, which people are talking about coming in 2 years, are great ways to bring broadband wireless capability throughout the United States. Not just throughout the United States, but everywhere in the world. You can reach tens of millions of more people in the U.S. with broadband capability in the rural areas than we do today, inexpensively. So it's a huge opportunity to bring technology like this, which just needs a broadband connection. It doesn't have to be a wired connection. It can be a wireless connection. To bring video conferencing, remote diagnostics. This is usually used in a hospital where you just need a short-range wireless network. Wi-Fi is fine. But any PC connected to broadband wireless gives you that connectivity, which allows that sort of remote diagnostics to take place. These technologies are available, they just need to be implemented. And we could cover the United States with this capability today if we so choose. And I hope that the $7 or $10 million in the stimulus package, which is put into this direction, will be used to bring this capability to those rural areas that really need it. So what do we need to do? We need to basically not just invest in technology today for today's sake. We can put a lot of great technology in place. We can do remote diagnostics. We can change the payment system in Medicare, Medicaid to promote the usage of these technologies. But we also need to use the innovation engine that the United States has to continue to improve. You know, innovation is defined as doing something in a new way and doing it better, cheaper, and faster, higher quality. You need to invest in R&D to do that. So some of the money that we're investing in the future ought to say, what does the endpoint model look like? What do we want to do? You know, the biggest investment that I know of in investing in how to use technology to advance care for the aged population is taking place in what country? Japan. No. Ireland. The Republic of Ireland, with its 5 million people, with private partnerships, invests about $30 million a year studying thousands of aged people, promoting better living, promoting those people staying in their homes longer, remote diagnostics, remote capability, keeping them out of the hospital. We need to have similar investments in the United States. Public-private partnerships of that sort. So let's spend some of our money in R&D and what the future looks like, as opposed to just squeezing the who pays balloon in the short term. You don't actually have to go to Ireland. You can go to the Veterans Administration. And one of my pet peeves with HHS has been when I suggested remote monitoring, remote diagnostics for chronically ill patients is good. The government has its own database, which is the VA, Veterans Administration. What I usually hear back, oh, they have a different population than the general population. We can't use their data. We have to do our own study. Then I say, well, let's go to Kaiser Permanente. They're doing the same thing. No, that's a commercial entity. We have to do our own study. Then I could go to all the commercial entities that are, in fact, remotely monitoring blood glucose level, weight, respiration rates, where people pay $50 a month for that monitoring capability, have a third party plot the data and inform them that there's something wrong. No, that doesn't count. We need to do our own study. Eventually, we have to stop doing our own study and take the data that's available in front of us and decide that's the endpoint that we want to go to and actually just do something. So take the VA study, 17,000 patients, 25% reduction in number of bed days of care, 19% reduction in hospital admissions, for a modest investment for remote monitoring telehealth. Modest investment, how much does one night in a hospital cost? For way less than one night in a hospital, you can provide all of the connectivity, remote monitoring capability you need. But you have to have that vision in place, that endpoint that you want to go to. Kaiser has very, very similar studies. I think there's available data to show where the healthcare cost is. 80% of it is targeted at a very small portion of the population. The only way you touch that portion of the population is with technology, remote diagnostics, remote monitoring. You have to change policies to get there. It's not just throwing money at it. You have to change policies. This is the town where policies are changed. So what I want to do today is write you all a prescription. If you all had a PC in front of you, I'd give you an electronic prescription, but it has to be an analog prescription. I want to write you a prescription for Brave pills. Okay? Brave pills are what you need to stand up and say, hey, let's change the debate. Let's change the debate from who pays and what the medical crisis is, the healthcare crisis. The healthcare crisis is a cost crisis. It's a system which is relatively dysfunctional, the highest price system in the world, and delivers mediocre results and is escalating by 200 billion plus a year. If you find that acceptable, then just squeeze the balloon and decide who you want to tax next. If you find that unacceptable, then let's figure out how to use technology to deliver medicine in the same way computing capability is delivered to you today. Remotely, individually, allow elderly people to live a better lifestyle at home, their surroundings, to allow chronically ill people to be monitored proactively rather than reactively, and let's change the system. But you have to have a vision, and you have to have your brave pills to do that, because you have to buck the system. The healthcare system is a series of entrenched entities, constituencies, who are all looking out for their self-interest and not the patient's self-interest. If you don't believe that, what do you think the American Hospital Association, I've consulted somebody in the audience, looks out for? They look out for hospital occupancy and return on investment. What do doctors look at? What do nurses look at? What pharma companies look at? What are any of the constituency insurance companies? Right down the list. None of them has the end user, the customer, in their mind. And that's where we ought to start. I've said enough to insult everybody in the audience. That was my job, I think. I think we have a couple of minutes for questions if anybody wants to dare ask a question. You have to go to a microphone, I think, on either side of the room.
It's Andrew Noyes with Congress Daily. Quick question. I was interested in what your thoughts are about the biggest challenges that you think government and the private sector are going to encounter when they start really having to implement the stimulus dollars for health IT.
I think the biggest challenge is what endpoint do you want out of the system? And it's not just throwing technology dollars at this. You have to decide that you are going to change the system, and that's a combination of policies and technologies. Throwing technology at the system, if you only reimburse for face-to-face office visits, in my mind, is a waste of time. So it's a combination of policy and practice. Electronic medical records are a great way to start. Broadband's an integral part of that, but you need to have policies in place to change the system. And that's where the brave pills come into play. Yes, ma'am.
Hi, it's Kim Dixon with Reuters. Are you saying that we don't need an overhaul of the entire system to make a dent into healthcare efficiencies? And I might have a follow-up if you want to answer that.
You know, I've got a doctor in front of my name, but it's not a medical doctor. I'm an engineer. I solve problems by looking at the constituents of the problem. 80% of the cost of the healthcare system is in the aged population and chronic illness. I would focus my energies on that 80% of the cost if I want to make a dent in the total system. And technology can play a huge role there, but it has to be technology with policy changes. You have to get into the business of proactive monitoring remotely elderly people and chronically ill people to keep them out of the hospital. You have to do exactly the same thing we did with computing capability. You can't just build bigger mainframes. You've got to diversify healthcare to the individual and in the individual's home. That takes policy changes and technology.
Thank you. My name is Cooper. I'm a director with a small health clinic network. We do about 100 million a year locally here. We are one of the few such institutions where the board is controlled by the actual patients, consumers, and we have leverage to, we think, to organize independent clinics all over the country into one. How would you suggest we invest in our own interest as consumers, assert ourselves in the direction you are suggesting?
Well, you can perhaps do the same thing we're trying to do as corporations, which is we are relatively small as individuals. Because I don't know how many patients your clinic serves, but
80,000.
well, you serve 80,000 patients. My company has 50,000+ employees with dependents and probably a couple 100,000 people. So what we try to do is to combine with others to get some form of critical mass. In our case, we're looking at other employers to try to change the system. The best thing I could suggest you do is perhaps to look at other relatively independent clinics to get a critical mass, to then use that as the message, that as the example of what can be done. As employers, we're trying to get out of the debate of electronic medical records and just provide all of our employees and dependents with electronic medical records. We're just trying to do something. So I'm suggesting you take a step of combining with others with like interests to try to get critical mass. There's a fortune cookie that describes what I'm suggesting to you and what we're trying to do. And the fortune cookie says, a small deed done is better than a great deed planned. We are in the home of great deeds planned in Washington, D.C. What you're doing as a clinic is a small deed done, which is by configuring your board to focus on patients. What we're trying to do as a corporation is a small deed done by giving all of our employees personal health records. That's how the system starts to get changed, by small deeds done, not by great deeds planned. So my advice would be combine with others of like interests, other clinics, to try to build up critical mass. That's what we're trying to do.
Thank you.
Yes, Bruce Hall with the American Homeowners Grassroots Alliance. There's stimulus funding for health IT, and separately stimulus funding for broadband expansion, which our next speaker is helping to coordinate. There's obviously a mission overlap, but they're two separate programs. How do we get them to work together to maximize the potential for both?
Well, part of my message today is, in fact, that you have to combine policy with vision with your expenditures. You just can't throw money at technology. And so my answer is that the Obama administration and its policies through HHS or its healthcare czarships decide what the endpoint looks like, and then decides, okay, I have 20 million for EHRs and I have 7 million for broadband. I want to combine that to make sure that I get closer to the end result as opposed to just point implementations around the board. So it's perhaps debates of this type, or discussions of this type, would say you need to have a long-range policy as opposed to just throwing money at technology solutions. I love technology, but unless it's combined with the right policy, you never get to the right endpoint. I see that I have a red dot by my name saying my time is over. My pleasure to have addressed you. Thank you.
Thank you, President.